My patient is a 28-year-old female, and she is presenting via telehealth for an intake appointment due to the need to change insurance providers. She is presenting with a history of complex PTSD and also severe depression. She was on psychiatric disability for the past 6 months and has recently returned to work. During her disability, she was severely affected by trauma, experiencing intense PTSD symptoms such as dissociation, irritability, sleep disturbance, and also an inability to drive. And she recently has expressed anxiety about leaving her home. She has experienced sexual assault in October of 2023. And upon her return to work from disability, she experienced another sexual assault around the same time this year. And so that is triggering all of her symptoms. She is a psychologist and she has a doctorate, and she works at a correctional facility for the criminally insane. And her last assault, she was assaulted by a patient. She struggles with anxiety, so we gave her the GAD-7, and she scored a 3, which is resulted in mild anxiety at the time she took the screening, and then also PHQ-9/5, minimal depression. Her anxiety is really triggered by being at work, and that is when it ramps up and it increases throughout the day. We used a biopsychosocial assessment. So asked her several questions about her history, her psychiatric history, her current medication, substance use history, family history, and personal history. We asked her several questions, such as how is your mood? How many hours of sleep do you get a night? How's your appetite? Have you unexpectedly gained or lost weight within the past 2 to 3 months? Who is your support system? Can you tell me more about the trauma you've experienced? Have you ever been hospitalized for psychiatric reasons? Have you ever been diagnosed? Have you ever taken psychotropic medications? If so, what have you taken and what was your response to them? Are you currently seeing a therapist? Do you have self-harming behaviors? And how are your current symptoms impacting your everyday life? So this is an example of some of the questions we asked. She has been on several medications, reporting that her depression has not responded to traditional SSRIs, SNRIs, tricyclics, or MAO inhibitors. While she was on disability, she underwent EMDR therapy and also ketamine therapy, both of which were effective. She has severe sleep disturbance. She only sleeps 2 hours a night, and she has lost 15 to 20 pounds unintentionally over the last month. She does deny suicidal thoughts, but she does have a history of self-harming behavior, and she does cut. She said that her anxiety is basically somatic, and it is manageable with her medications. She does feel extreme isolation, and it's hard for her to leave her home, and she doesn't have people that she can identify as a support system. Her current psychotropic medications are lithium, trazodone, prazosin, propranolol, gabapentin, and Vistaril. She does drink alcohol socially. She did start using cannabis 5 years ago and uses it daily to increase her appetite. And she drinks a cup of coffee a day. She's allergic to penicillin and Norco, and she has a diagnosis of fibromyalgia and spinal fusion. No history of seizures. She doesn't use any over-the-counter medications. In her family, her uncle is bipolar. Her sister is bipolar. She is single, never been married, does not have any children. She lives with her cat. She's bisexual, not currently in a relationship, and not sexually active. She is not on contraceptives at the time. She does have trouble coping and has trouble with work performance. The differential diagnoses that I've selected for this patient are PTSD, major depressive disorder, and generalized anxiety disorder. Per the DSM-5, PTSD is most likely, and in major depressive disorder and generalized anxiety disorder. And I'll tell you now as related to the DSM-5. So for PTSD, she has had exposure to sexual violence by actually experiencing the event. She has recurrent, involuntary, intrusive, distressing memories and dreams of the event. She has dissociative reactions. She has a history of depersonalization and physiological reactions such as extreme nausea. She has markedly diminished interest or participation in significant activities, as evidenced by not liking to leave the house and decreased socialization with people at work and in her personal life. She has feelings of detachment or estrangement from others, self-destructive behavior, sleep disturbance in the form of insomnia, and the duration of that disturbance is greater than 1 month. And the disturbance does cause clinically significant distress or impairment in the social and occupational areas of functioning. And it is not attributable to the physiological effects of a substance. For major depressive disorder, per the DSM-5, the following symptoms have been present during the same 2-week period, and one of the symptoms is loss of interest or pleasure. And those are markedly diminished interest and pleasure in almost all activities, significant unintentional weight loss, decrease in appetite, insomnia, loss of energy, feelings of guilt. Also, the symptoms do cause clinically significant distress in social and occupational areas of functioning. The episode is not attributable to the physiological effects of a substance. Her depressive episodes are not better explained by the schizophrenia spectrum or other psychotic disorders, and there's never been a manic or a hypomanic episode. For generalized anxiety disorder as attributed by the DSM-5, excessive anxiety and worry for at least 6 months, and this is about work. It's difficult for her to control her anxiety and worry, and it does increase as the workday progresses. The anxiety and worry are associated with sleep disturbance, being on edge, and difficulty concentrating. The anxiety is clinically significant, causing impairment socially and occupationally. There is no substance the anxiety can be attributed to, and it's not better explained by another mental disorder. The mental status exam was largely unremarkable, except for noticing depression and some anxiety. So the way that we would treat this patient, first, we want some lithium levels. She did say that she cannot remember when her last lithium level was drawn. So that is imperative that we get lithium levels. We will continue her current regimen of lithium, 600 milligrams PO twice a day. Continue propranolol, 10 milligrams PO 3 times a day, PRN for anxiety. Continue gabapentin, 300 milligrams PO 3 times a day for anxiety, PRN. We're going to increase the trazodone from 150 to 200 milligrams QHS, PRN for insomnia. We're going to continue the Vistaril, 25 milligrams PO QHS PRN for anxiety, and we're going to add an additional 25 milligrams PRN for anxiety or insomnia. We're going to order kidney function and thyroid function tests, restart EMDR therapy for the recent trauma, also put her in trauma-focused CBT. Instead of using a sharp object to harm herself, if she has those kinds of urges, we're asking her to use ice or a rubber band instead. Discuss birth control with the PCP and get on it immediately. Obtain previous medical records. Exposure therapy. So we don't want to forget lifestyle changes. Stand outside for 20 minutes daily, maybe for a week, then try to walk down the street. We did provide psychoeducation about marijuana. Gaining support from somewhere might be an option, and maybe volunteering. If the current regimen does stop working, we could always augment the lithium with Abilify. Depending on her blood lithium levels, we could increase the lithium dose, restart the EMDR, and then possibly she'd be a candidate for ECT and TMS. Thank you so much for listening.